नमस्ते बिटिया, हमेशा खुश रहो बिटिया। A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about ST segment elevation, myocardial infarction. In the previous lecture, we have discussed about non-ST elevation, myocardial infarction. Acute myocardial infarction is one of the most common diagnoses in hospital patients in industrialized countries. More than half of the acute myocardial infarction relates deaths that occurs before the stricken individual reaches the hospital. The STEMI or ST elevation myocardial infarction usually occurs when the coronary blood flow decreases abruptly after a thrombotic occlusion of a coronary artery previously affected by the atherosclerosis. Slowly developing high-grade coronary artery stenosis do not typically precipitate STEMI or the ST elevation myocardial infarction because of the development of a rich collateral network over time. ST elevation myocardial infarction occurs when the coronary artery thrombus develops rapidly at the site of vascular injury. The injury is produced or facilitated by factors such as cigarette smoking, hypertension, and lipid accumulation. The histologic studies indicates that the coronary plaques prone to disruption are those with a rich lipid core and a thin fibrous cap. After an initial platelet monolayer forms at the site of disruption, plaques various agonist promotes platelet activation. After agonist stimulation of platelets, thromboxane A2 is released. Further platelet activation occurs and potential resistance to fibrinolysis develops. Fluid phase and clot-bound thrombin participates in an autoamplification reaction, leading to further activation of coagulation cascade. The culprit coronary artery eventually becomes occluded by a thrombus containing platelet aggregates and fibrin strands. The amount of myocardial damage that is caused by coronary occlusion depends on the territory supplied by affected vessels, whether or not the vessel becomes totally occluded, the duration of coronary occlusion, and the quantity of blood supplied by the collateral vessels to the affected tissues. I will again repeat, this is an important thing. The amount of myocardial damage caused by the coronary occlusion depends on the territory supplied by the affected vessel, whether or not the vessel becomes totally occluded, the duration of coronary occlusion, and the quantity of blood supplied by the collateral vessels to the affected tissue. The demand of oxygen of the myocardium, whose blood supply has been suddenly limited. There are various endogenous factors that can produce early spontaneous lysis of the occlusive thrombus, and the adequacy of myocardial perfusions in the infarct zone when the flow is restored in the occluded epicardial coronary artery. Now we come to the clinical presentation of STEMI or ST elevation myocardial infarction. The precipitating factors includes the physical exercise, emotional stress, or a medical or surgical illness. We have physical exercise, emotional stress, or medical or surgical illness. The pain is the most common presenting complaint in the patients with STEMI. The pain is deep and visceral, with a heavy squeezing and crushing that is occasionally described as stabbing or burning. So the pain is important. The pain is deep and visceral, with a heavy squeezing and crushing that is occasionally described as stabbing or burning. The pain commonly occurs at rest and is usually more severe and lasts longer. Typically, the pain involves the central portion of the chest and the epigastrium, and on the occasion it radiates to the arms. Less common sites of radiation includes the abdomen, back, lower jaw, and the neck. The frequent location of the pain beneath the xiphoid and the epigastrium. It is often accompanied by weakness, sweating, nausea, vomiting, anxiety, and a sense of impending doom. So it is presented with weakness, sweating, nausea, vomiting, anxiety, and a sense of impending doom. The pain does not subside with cessation of activity. The differential diagnosis includes acute pericarditis, pulmonary embolism, acute aortic dissection, costochondritis, and gastrointestinal disorders. The physical finding includes most of the patients are anxious and restless, with attempting unsuccessfully to relieve the pain by moving about in the bed, altering their positions and stretching. The pallor is associated with perspiration and coolness of the extremities occur commonly. The combination of substernal chest pain persisting for greater than 30 minutes and diaphoresis strongly suggests STEMI. The lab finding includes the diagnosis may be divided into 4 subgroups. We have ECG findings, serum cardiac biomarkers, cardiac imaging, and non-specific indices of the tissue necrosis and inflammation. ECG, serum cardiac biomarkers, cardiac imaging, and non-specific indices. Now, in the ECG, the patient initially presents with the ST segment elevation that ultimately involve Q waves on the ECG. The serum cardiac biomarkers consist of cardiac specific troponin T and cardiac specific troponin I. The cardiac imaging consists of two-dimensional echocardiography, that is 2D echo, radionuclide imaging techniques like 201 AI or 99 MTC, SystemVB. Now, how will you manage such a case of STEMI? It consists of pre-hospital care that includes the occurrence of 2 general classes of complications. Number 1 is electrical complications that includes arrhythmias and mechanical complication that causes pump failure. The major elements of pre-hospital care includes recognition of the symptoms and prompt medical attention, rapid deployment of the emergency medical team, expeditious transportation of the patient to the hospital, and expeditious implementation of the reperfusion therapy. Now, management in the emergency department consists of the goal include control of cardiac discomfort, rapid identification of the persons who require urgent reperfusion therapy, triage of lower risk patient to appropriate location in the hospital, avoidance of inappropriate discharge of patient with STEMI. Aspirin is essential in the management of patient. Oxygen should be administered by nasal prongs or face mask. The control of discomfort is done by sublingual nitroglycerin. Morphine is very effective analgesic, and intravenous beta blockers are used to control the pain. The pharmacotherapy or the medication consists of antithrombotic agents like aspirin. It is the standard antiplatelet agent for the patient with STEMI. Beta adrenoceptor blockers that improves the myocardial oxygen supply demand relationship, decreases pain, reduces infarct size, and decreases the incidence of serious ventricular arrhythmias. The inhibition of the renin-angiotensin-aldosterone system consists of aspirin and beta blockers, and the agents consist of intravenous nitroglycerin. Other agent includes intravenous nitroglycerin. So this was all. This completes the course, the complete course of practice of medicine, and in this way, the whole of the course of practice of medicine is complete. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve them. So today the cardiovascular system is also complete, and we have covered all the chapters of practice of medicine. If you have any query, you can directly contact me so that your problem could be resolved. So in this way the course is complete, and thank you very much. This was all for today. And now in the further subsequent sessions, there will be only revisions of the topics. Thank you.